All right, good evening, everyone, and thank you so much for joining us at MSU tonight. We're very excited about this webinar, introducing you to, I don't know, I would say one of the most caring doctors that I've come across in a long time, especially with the patient and caregiver focus. So we're really excited to introduce you to him tonight. Um, and we thank you for joining us. It's After Diagnosis, the Burden of Care in the Evolving Doctor-Patient Relationship with Dr. Salman Bhai. And in this webinar, Dr. Bai is going to talk about best practices as related to myositis care and empower you to seek the care you deserve. He's also going to discuss ways you can guide research efforts to help understand and cure myositis, and he's going to answer the questions that you asked during registration. Dr. Bai's own words: your disease doesn't start and stop at the doctor's office, and neither should your care. You aren't alone in this process. Let's make sure of it. So first, joining us tonight from Myositis Support and Understanding, my name is Jerry Williams, and I am the founder and president. Lynn Wilson is joining us, Vice President and Director of Patient-Centered Research. And Manuel Lubinas, he's the Patient-Centered Research Advisor. And time permitting, Dr. Bai also will take some additional questions. If you locate your Q&A icon in the Zoom toolbar, and if you click on that, you'll be able to ask questions. We'll do the answering. You can ask your questions there. If you have any technical questions or anything else, you can use the chat section, and one of us will get back to you there. So with that, I would like to introduce Lynn Wilson, who is going to enthusiastically introduce you to Dr. Bai. Lynn?
Hi, everybody. I just want to quickly introduce Dr. Bai, and then we'll get going. Dr. Bai is assistant professor at the University of Texas Southwestern Medical Center in Dallas. He's in the Department of Neurology and Neurotherapeutics. And he's also a faculty member of the Institute of Exercise and Environmental Medicine at Texas Health Presbyterian in Dallas. He has his BA in genetics from Duke and his MD from Harvard University. He served an internship at both Harvard and Brigham and Women's, and his final fellowship and residency in the joint program was at Mass General Hospital and Brigham and Women's, where he served under several very well-known specialists in the field of myositis. So without further ado, I'd like to welcome Dr. Bai, and let's sit back and listen to what this gentleman has to tell us.
Well, hopefully it's a discussion with our patients here and everybody else. And I want to thank you, Jerry, Lynn, Manuel, the MSU community. It's really an honor to be here speaking with you today. I really get my inspiration from people like you, people with myositis, their caregivers, and I'm happy to share my thoughts today. Just a quick disclaimer, as always, these are my thoughts and not that of UT Southwestern or Texas Health, but they're proud supporters of the myositis group, and that's what we're here to talk about today. So, this first slide here, myositis has changed a lot since the initial discovery of what it was and how it's evolved over time. And the talk for today really is not about the science, the disease, the diagnosis, the treatment, right? We know these things and we talk about them all the time. You probably think about them and talk about them way too much. But how can we go from the disease process to understanding the illness and how to treat the person, how to treat the caregiver? So my view of what the clinic of the future of what your care should look like is almost like a checklist that I keep in my head and on paper, which I'm happy to share, about how you should go about your care. It should always be multidisciplinary care, right? It shouldn't just be you and your doctor. I listed several supports here, including psychological support. Let's forget about the physicians and the nurses for a moment. Of course, they're important, but I think there's more important pieces here once the treatment has been started. You have your speech therapist, your physical therapist, your occupational therapist, social work, nutrition, respiratory, pain management. You have your advocacy groups, and then I mentioned self-care and caregiver support. I think these are very important parts that sometimes get neglected, right? You might get reduced to What's your strength like in your deltoid, right? Can you put your arm up for me or not? What's your CK, right? You're not a CK, you're not a level, you're not an aldolase level, you're not an antibody, right? You're a person who feels, you're a person who is experiencing this illness. And I think it's of utmost importance for that to be addressed by you, by your caregiver, and by your providers. So I think that's some of the framework for how I approach clinic with patients like you, and how I imagine the future of myositis care to be. The important part about changing what myositis looks like outside of the clinical care is research. And I think patients and their families are key drivers and should be key drivers of research. Sure, the doctors and the scientists are coming up with projects and describing what they should be doing, but it's through listening to you all, what you feel, what you understand of your disease, that can help guide disease. And it's not just that clinical phenotype, that clinical picture that you have, but it's also how you progress through the disease and participating, right? So one way to participate is to help create a biobank, to organize around a particular disease or subgroup of disease, and work with your doctor or doctors who participate in this, whether it's clinical trials or collecting samples, to do that and understand how we can take what you're experiencing, what your body is showing chemically, take it back to the bench and translate it back to patients, and eventually take it to the community, right? It doesn't do us any good if it's stuck in the lab or stuck with a few individuals. We want our discoveries to affect broadly, whether you're here in an affluent area, a resource poor setting. All patients with myositis should get ideal care and be able to guide research.
For those who might not be familiar, Dr. Bai, could you just explain what translational science kind of means in a nutshell?
Absolutely. You know, it has a broad meaning depending on what you're translating, but the way I see it is that you want to take what you're doing in a lab or addressing from a person and translate it into actionable items, right? I wish it was fast and easy like that, but unfortunately, it takes years. And if we're actually focusing on translation, we may be able to cut that time by saying, you know, our end goal is a patient. It's not a paper. It's not starting a company, which all of those things help the patient. But I think keeping your focus on the patient to say, what can we do to take this discovery and take it to our patients so that we can help them?
Great, thank you. I appreciate that.
Absolutely.
And all of these, the guiding research part, if you read the article that we posted, myositis patients and families come first, introducing Dr. Bai, these are some of the things that we're going to be working on together. So please, gear up and get ready, because we've been pushing the time is, time for waiting is over. And, there's something that all of us can do as patients and caregivers, not only for ourselves, but to help guide research and, ensure that we're kind of moving forward. So,
absolutely. Jerry, you brought up a great point. It's a team effort. I think, I don't want to get caught into the nuances of saying, oh, I'm just a guinea pig, or, I'm just a research subject. You're not, you're just anything. You are the driver of this research. And it's the relationship that you have with your doctor, with your researchers, to say, this is what I think is the next step going forward. And, I'm willing to donate my sample, whether it's just blood or after a biopsy, to say, sure, you can work on my biopsy to see what you can find. I think it's having this in mass working together that we can actually make change happen.
Thank you. Yes, it is a team effort. And please keep an eye out, everyone that's listening, for some of these opportunities to get involved. Would you like to start with some questions, Dr. Bai?
Sure, absolutely.
So, talking about a myositis clinic of the future, translational medicine, functional medicine, exercise medicine, what do you see as the myositis clinic of the future?
And that's a great question. And I'm sure that's a question on a lot of people's minds. And I see a comment too that, yeah, multidisciplinary approach definitely is the goal. But unfortunately, in some areas, as I'm sure you're all aware, that myositis clinics or these interdisciplinary clinics don't exist. And I think that's unfortunate. But I think the big picture here is that how can we have continuous multidisciplinary care even when you're not in the clinic. And I think the field is changing, right? We have wearable technology on us. There's research being done on that, and I'm looking into that as well to say, how can we predict a flare before it happens or catch it quite early? It's a clinic that integrates clinical care with taking samples back to the lab and having a deep understanding of what your disease looks like and what does it mean biochemically. And then this exercise component, I think, is quite important, right? There's a misconception that exercise may harm you. And I know MSU has done a talk about this in the past, and it's becoming more mainstream, but exercise can have numerous positive benefits, not only on your mental health and your physical health, but what your muscle is saying, right? What your muscle is communicating to the rest of the body shows signs of healing. So I think that's an important part too. This concern that multidisciplinary care is not achievable in a lot of areas is true, unfortunately. And I think if we strive for the ideal, if we understand what it should be, then I think ideally we will land somewhere in the middle that is centered around patients, right? I don't want a patient traveling to 10 different providers on different days because, of course, it's hard to get around. There's COVID happening. So if we can consolidate all this, I think that would be beneficial for patients. But again, this is all ideal, and the goal is to break barriers. I think part of my goal in approaching myositis is to say, sure, you don't have that many myositis patients in your location, so unfortunately, you're telling me that it doesn't make sense to create a clinic just for this. And my response would be, well, what if we had a general kind of format, right? What if we had a clinic that made it easy for patients like myositis, ALS, and other conditions where you can piggyback off of the existing infrastructure, right? That might be an easier way for an institution who can't justify a myositis clinic, but can integrate these different forms of care all together.
Excellent. Now, and I'm not sure if you're prepared to answer this, but a lot of us do travel to a myositis clinic. For example, I travel to Hopkins. I'm lucky that it's only a 2-hour drive each way, but that is a very difficult day. Do you see, physicians within the myositis clinic of the future working together with, say, local neurology and rheumatology physicians, where the patient could maybe go for an initial visit, maybe like every year or so, and then work together with a local doctor? Is that achievable?
I hope so. And a lot of it depends on the goal, right? As you all are aware, and you all can probably attest to, is that the diagnosis for myositis may have taken some time to be correct in you and may have even been misdiagnosed at one point. And so I think there should be a back and forth, right? Not every place has an academic center. But what I do with my patients is if I get a referral, I write a detailed note that can serve as a subtle education tool for folks coming in. And I learn from the community physicians as well about what they're seeing and how this presented. So there's back and forth on that way. And then what I tell the patient is you can work with the doctor that's local to you and it's easier. We communicate through telemedicine. We send notes to each other. And over time, whether it's 6 months, a year and a half, we have these intermittent visits. Telemedicine has really changed a lot. As you're all aware, right, we check your strength often and determine a lot of the care based off that. So that makes it a little difficult. But if you've been stable, if there's room for making it a bit easier on you, I think that's worth pursuing.
Excellent. Thank you.
Okay, Jerry, I'll take this next question.
Thank you.
You're welcome. Why are some patients seen by rheumatologist versus neurologist or dermatologist in myositis? Do we really need all these doctors? Who knows more about my condition?
Well, it's good and bad to have too many cooks in the kitchen. And I think the big picture here is that you should have a quarterback. You should have someone who's managing this as your primary doctor. And it's likely one of those people. They all have subspecialties, right? So neurologists, I'm a neurologist. I deal with these problems, but the rheumatologists have more experience when several other organ systems might be involved more heavily. The dermatologists are very skilled at dealing with skin issues because of the name, obviously, and their training, but they have a different set of approaches that rheumatologists and neurologists won't have. So I think in the way I work with providers is to always communicate. And I even tell my patients that, look, make sure if you go to somebody else and I don't have access to your records, please send them to me. I do think it's, at least initially, if you have symptoms, to see these different kinds of doctors if your doctor's uncomfortable. And then over time, as things settle out, I think you can slowly back off and say, look, I haven't had a rash in a long time. I'll talk to my dermatologist and say, I'm clear. If something comes back, can I make an appointment? Right? And I think doing that will free up your time. Like you're saying, you might travel for a long time. It takes a lot for you to get out. Why spend all your time in the hospital? Why spend all your time in the clinic? Right? Have that point person help manage these things for you.
A quick question to follow up on that. Are neurology and, so I guess maybe rheumatology and neurologists, do you get trained on the skin components of, say, dermatomyositis?
We do, and it really depends on the institution and the people you work with. So I've been lucky to have wonderful mentors who dealt with this often and would comment on these kinds of conditions, would comment on how to treat these. But even after all of that, I think it depends on the doctor's comfort level, right? So if you've had the training but you still feel uncomfortable, then it's almost better to have a doctor, or it is better to have a doctor that says, look, I don't know, and I'm going to transfer you and work with your dermatologist to help solve this. So I think it's really important for the doctor to know his or her own limit and to communicate with your whole team.
Great, thank you. Are you aware of any expert facility like a Johns Hopkins or a myositis clinic close to the Louisville area?
You know, as I was looking this up to see how far the drives would be, the two centers that I could come up with are Duke and UPMC. That would be painfully long drives, unfortunately. But University of Louisville is an option too, and I think it really depends on your doctor. I think that's what makes it difficult, right? You might go to an academic center or a large community practice and see someone who doesn't know much about myositis. I think the big goal here for you is to advocate for yourself and to not give up. So if you think something is off, I think it's always worth speaking up to your doctor. If there's education materials you think your doctor would benefit from, you could do that. And now in the age of telemedicine, it really depends on what your question is, right? So you alluded to this earlier, Jerry. If you have a local doctor and someone far away, they can communicate and you can do a telemedicine visit, right? Someone can review all of your data and say, this actually looks great. You're going down the right direction. So I think it is a team game and back and forth. It really depends on your question and what you're looking for.
Okay, next up here is, I have a regular doctor treating me for inclusion body myositis. Is there a way for him to get better information on how to help me? Where can he go? He put me on steroids for a month and it lowered my CK. After decreasing steroids, my CK is higher than before.
This is part of the dilemma and what's most funny about myositis to me. Our medicine is getting so advanced, cancer therapy is so advanced, we have very specific targets for different kinds of genetic diseases, for different kind of markers on tumor cells. But with myositis, we're literally pushing and pulling on muscles and checking CK, right? So I think all of you have probably experienced that your muscle strength doesn't always correlate with the CK. So that's one thing. And I think that's always good to take a step back as a doctor and say, you're not just a CK value. I'm still feeling weakness here. And what's it from? Is it from steroids? Is it from disuse atrophy? Do we need to exercise more? Do we need to come off steroids? That's one thing. The first part of the question, where can my doctor get more information? I think these advocacy groups are a great starting point. And I hope, you don't have a doctor where there's some offense taken if you hand over materials. I think it's a useful thing. And I always find it useful when a patient brings up something because one, I might learn something here, and I usually do. And two, the patient feels more comforted, right? You heard the patient and you listen to them and address their concern. But I think starting with these organizations is good. And then step two is looking at resources like UpToDate. Some of you may have heard of this, and they have patient resources too. But it's basically like a Wikipedia for doctors that's edited by doctors. And they're just brief articles. They give you a good sense of what's going on in the field and a great resource for a quick introduction. The second part about this with inclusion body myositis, right? Some of you may be on treatment or have been on treatment. The prevailing thought around this is that it doesn't respond to immunosuppression, unfortunately. And it's devastating to see yourself struggle with the disease without having treatment for it. But I think that doesn't mean we don't treat it, right? There's non-pharmacological treatments for this, like physical therapy, occupational therapy, nutritional support. I think those are important components to the care, especially exercise. So whether CK is brought down by steroids, which does happen and which we do see and does not always correlate with strength, I think just points to this idea that this number should not be the end all, right? And the treatment shouldn't just depend on that lab value. There were a lot of questions in there, so I went a little bit back and forth, but I think the big picture here is work with your doctor, show them the advocacy group resources. There's professional resources like UpToDate. You're not just a CK value, and steroids might lower that, but you still might be weak. And it's important to understand where that weakness is coming from.
Moving on to a very controversial subject for the myositis community. Pain has, as you are probably well aware, there's some doctors that still say that pain is not a part of myositis, and that's, period, that's it.
Yeah.
And now there's, newer doctors that are, being trained differently that pain can be. So why can there be pain and fever in myositis?
Yeah, that's a great question. And you're right about the controversy, because I do remember reading in some sources that this is a painless weakness.
Right.
And then anything that doesn't fit, doctors will say, sorry, it's not there. and that's unfortunate, because pain is one of those subjective symptoms that we don't really have a good measure for. We look at your vital signs sometimes and say, it looks like you're in pain. We look at you and we say, you look like you're in pain, but only you know if you're in pain. And so I think this goes back to the relationship with your doctor, that if you have pain, it should be treated and it should be understood from where it's coming from. Pain with myositis happens because your muscles aren't just inflamed. You have different compartments of your body that can be inflamed. Right, so that's one thing. And when these different compartments are inflamed, it can cause pain. Right, there's nerves in all of these different kinds of parts of your body, like fascia, muscle, nerves, joints, skin. The pain and the fever come from a similar source. Right, your immune system is activated. There's different aspects of your immune system, and it's quite complicated. The end goal is eventually that you get this milieu of cytokines, these signals that say, body go attack, body get activated. And unfortunately, your body then attacks yourself. But as part of that process, just like when you attack a virus, you may get fevers, you may get myalgias, right? That achy feeling that can be nonspecific sometimes, but it's there. You can feel fatigued, right? All of these symptoms go along with this, right? Not always clear cut. And it may not be directly related to the myositis, right? So if you're weak, say you've twisted your ankle before, you may have noticed that if you're walking funny for a little bit, some other joint on the other leg might start hurting, or a muscle might feel strained on the other leg. And that's because when you have musculoskeletal imbalances because of your weakness, then you can get pain from that. So I would urge you as patients and caregivers to understand pain from multiple perspectives. And that's why I think physical therapy and occupational therapy are very important. I joke that I think everybody, whether they're, everybody's a person, everybody's not just patients, but everybody should have a physical therapist, a psychologist, or a counselor to work with them, and then a dog, or something that makes them very happy. I think it's very common for us to have these imbalances. It's very common for us to have psychological triggers of pain that amplify the pain. And then it's important for us to take care of ourselves, to try and work past the pain.
Excellent. And we, not only are there other psychological factors involved, but, pain is not only physical, but there is that psychological component of pain itself. And sometimes that's misconstrued by patients when we don't really understand and we're not educated enough about the pain. So when a doctor says, that it's, maybe more of the psychological part of the pain, see a counselor, I think that conversation needs to kind of be worded in a different way so that the patient understands you're not telling them that it's all in their head.
Oh, I completely agree. And I think it's so hard to have that conversation in a delicate way. And it doesn't necessarily have to be delicate because patients are delicate. I think it just has to be delicate because the balance and relationship between the doctor and the patient should be there, right? If you trust your doctor and your doctor trusts you and understands you, you don't just say it's in your head, go deal with it. The way I describe it to patients is that, not to get too much into the weeds, right? But the mind and the brain, they should be in the same place, but they're not necessarily, right? And we should treat both of them. And just because something is in the mind and I can't point to it with a test doesn't mean it's not there. It means I don't understand it, but you feel it and you experience it. And that's why I think this multidisciplinary approach, where you're trying your best to take care of yourself in terms of your mental health needs, your emotional needs, what you do to have fun, despite feeling weak, tired, fatigued, are all important components on treating these kinds of disorders.
Great, thank you. And that goes into the next question is, how can we educate doctors that tell these patients that there is no pain with myositis? We see it a lot in our support groups. I went to my doctor today and, we talked about my pain again, and he continues to say it's a painless disease. There's nothing I can do to help. Mm-hmm. And, pain being the controversy that it's in with the opioid, epidemic and all of those other factors. Do you have any tips on that by chance?
Yeah, I think it just goes to educating the healthcare community in general about myositis, right? There's fields that I need to learn about, and then there's people who need to learn about myositis. It's just a back and forth and a lifelong process. And I think patients help us do that, right? They confront us with problems, and then we have to work with patients to deal with them. So I think one is really explaining to your doctor that, look, perhaps it's not from myositis, but what if it's from a muscle imbalance? What if it's inflammation in a different area that's causing issues? What if my joints are being damaged? There's different things to think about. And then there's unfortunately, different doctors too, right? So we're adding more cooks to the kitchen. But other doctors like PM&R, going to physical therapy, doing occupational therapy, I think these different kinds of aspects may lend themselves to a different perspective. Right. And so then there's feedback, right? So say something happened with one of these doctors and there was good relief. Well, you would take it back to your doctor. They would see the note and you would say, look, like they tried this on me and it worked like magic, or it helped. And, I think this is a good thing to try in the future.
Great. Thank you. Lynn?
Yes. After the diagnosis of this is a category that we've called diet and mood. Mm-hmm. But after the diagnosis of IBM, the only advice I am is moderate exercise, healthy diet, maybe supplements like vitamins, CoQ10, fish oil, keeping a positive attitude, and plan for the future. What else do I need to do?
I think that's a good start. right? I think diet, mood, exercise play a big component of your daily experience, right? So that's an important part to always keep in mind and always try to center yourself back and say, what can I actually do? What can I control in my life to help me feel better and let me enjoy the people and the experiences that I want to, right? So I think that's a good start right there. Unfortunately, the field is behind, right? So there's some data that creatine might be helpful for IBM patients, especially with their fatigue. So that's one thing that I see that's not on there. Uh, Outside of that, unfortunately, there's not too much, right? And then there's different kinds of exercise. There's resistance training, there's aerobic training, there's blood flow restricted training. Those all seem to help, and it's useful to do. But I would caution you not start this all of a sudden. I would talk to your doctor and make sure it's safe for you. But focusing on these is important, and I do agree that doing this is helpful to you.
Great, thank you. How can good or bad diets affect myositis, and what can I do as a caregiver?
Again, a great question. I think one of the failings of Western medicine is understanding diet.
Yes.
We just, going back to my medical school experience, we rarely talked about it. And even during training, we don't talk about it much. But I think there's definitely data that shows not necessarily certain foods. Certain foods do and can lead to this low-grade inflammation. And there's some thought that perhaps that's associated with cardiovascular disease and this metabolic syndrome, right? Obesity, diabetes, hypertension, hyperlipidemia. All of these factors are somehow, we think, related to diet, exercise, our lifestyles. So I think having a bad diet only harms you because it might be harming other systems that are trying to compensate for myositis. I haven't seen clear data that says, if you eat X, Y, and Z, it's going to lead to a flare-up of your myositis. And similarly, I haven't seen that if you eat A, B, C, like your broccolis, apple, carrot, I don't know, it's going to help your myositis. But it will make you feel better. It will give you more energy. The way I counsel my patients on diet is that it's very simple, right? If you get too into the weeds, if you're reading every little thing, it's hard to sustain. What I say is you should be eating food that goes bad, right? So that means it's fresh. Staying away from red meat the best you can. Eating fish if that's allowable for your diet. Heavy fruits and vegetables. And then a colorful plate, right? So that means you're adding variety. Doing so and staying away from processed foods, I think will just overall benefit your health and keep you away from having diabetes, cardiovascular disease, high blood pressure, high cholesterol. Because unfortunately, what we do for those is say, take a pill rather than saying, you need to go exercise, you need to eat healthier, and that will help. If it doesn't, then we start adding medications. And as you know, all medications have side effects. So it's like this snowball kind of effect.
Totally agree. Any ideas on what they could do as a caregiver to help?
Oh, yeah, thanks for bringing that question up.
Oh, that's okay.
I think as a caregiver, you want to give care, right? It's just inherent. But and before I jump into that question, I want to emphasize that you should also be taking care of yourself, right? Caregivers need help. Caregivers burn out. It's okay to admit that. It's okay to feel that. You shouldn't feel guilty. And I think understanding that and taking care of yourself will allow you to take better care of your loved ones. And so as a caregiver, I think you should do what makes you and your the patient feel better, the loved one feel better. And so in relation to your diet, right, if the person that you're caring for likes certain foods, likes fresh foods, enjoys going grocery shopping with you, caution with COVID, but enjoys doing these things with you, I think it's that emotional support that's important. And then making sure that the patient is getting the right nutrition, right? So at some point, sometimes patients have difficulty swallowing, they lose weight. And I think that's a red flag, right? That's something to bring up with your doctor. That's something to say, I need to increase my calorie intake. I need to stay on top of this person to say, hey, drink some water or eat more of this, or let's have a more calorie dense kind of item here.
Great. Yeah, and putting that focus on taking care of yourself as a caregiver, it's it's easy to say, right? And you know that.
Yeah.
It's very easy for us to tell, caregivers to do that. And putting that into practice, when you don't have time, you're working full time, you come home to care for your loved one. So, we've been trying to do some webinars or put some webinars together around some actionable things that caregivers might be able to do. And rather than just saying, just take care of yourself.
Yeah, absolutely.
Very hard.
You can't just say, feel better, right?
Right.
That's not a solution. So, you all are doing a wonderful job about how can we translate this, right? There's that translation component again. How can we translate this from an idea to just actual concrete actions?
Excellent. Thank you. So moving into medications and clinical trials, Lynn?
Yes, the question, and there's another one in the Q&A box that I'll follow up with, but basically, how do drugs like statins affect my disease? Does muscle damage reverse after stopping them?
That's a great question. And, there's a lot of not so much controversy, but there's a lot of worry with this, right? So statins are prescribed like water, basically. There's so many patients I see that basically I can't remember one that is not on a statin. They're just so common because of this lifestyle, diet, genetics. You get hyperlipidemia, high cholesterol. And of course, we want to treat that, but we know that statins affect a pathway in our bodies that lowers cholesterol, which is great. It may have an anti-inflammatory effect, which is great. Doesn't seem to affect these kinds of diseases in a good way, because statins can sometimes affect the production of these molecules that are important for maintenance of skeletal muscle architecture. That's part one. They also help produce antioxidants. So if statins stop all of that, now you're stressing the muscle. And, you all may have heard of the two-hit hypothesis, where, you may have been predisposed to this for whatever reason due to genetic abnormalities or differences. And then the second hit came when you had an agent like a statin that unveiled the myositis or the myopathy. Or the second hit could have been a viral infection that revved up your immune system. But the idea about statins is that, yes, they can cause myalgias with or without CK elevation. They can cause a myopathy, and then they can cause the terrible end stage of this, which is the immune-mediated necrotizing myopathy. Right, and those patients are very weak. It's explosive presentation. And the good thing, though, I found working with my mentors and through my experience as well, is that at least with the statin myopathies, they respond quite well to IVIG. And once you stop the statin, there is recovery and improvement in strength. This is not for all patients, unfortunately, but the damage does stop when you stop the statin. Again, this is not true for everybody. There's some patients I see that continuously have weakness or a high titer, and that takes a bit of rethinking and more personalized care to understand why is this person still weak? Did we treat them too late and there's fibrosis or permanent damage of the muscle? Have there been steroids for too long that then led to atrophy of some muscles and not concurrent physical therapy? Right? And has the person been too weak for too long where other muscles are starting to get weak because they're not moving? Right? So I think it's always worth taking a step back and making sure that you're on the right diagnostic pathway.
And just to follow up for those that are listening that maybe don't have immune-mediated necrotizing myopathy, this is more specific to that disease. There are, with statins, there are those rare those muscle side effects that some people get, that when they stop the statin, everything goes back to normal. They don't get this necrotizing myopathy.
Absolutely.
So
thanks for bringing that up. I don't want,
sure.
If you're on a statin, I don't want you to stop it all of a sudden because you have myositis and you're on a statin.
Right.
I think this is a very different category of disease. And it's really a personalized decision with your doctor, right? Some of these patients, some of you may be taking statins and are doing completely fine, and that's great. Some of you might start it because your doctor says, hey, you had a heart attack, we really need to start this. And then you might get myalgias and you can come off it and it reverses. So it's a very personalized decision, and this is a very specific subset of disease.
Thank you for clarifying that. Are you, I don't know, I'm sure that you might have some information on this, but do you know what the status of the clinical trial is, the phase 2 clinical trial for KZR616? And is it a replacement, or will it be a replacement for steroids?
Yeah, these preclinical names are always so funny. They seem so robotic, and then pharmaceutical companies eventually translate them into more appropriate, easy sounding names. But this KZR616 is interesting, and there's other trials too that are ongoing that are interesting. The way this one works is that it's an immunoproteasome inhibitor. These proteasome inhibitors. There's one of them, bortezomib, that's used for myeloma. They were discovered back in the 90s, and this bortezomib was approved in 2013. These immunoproteasome inhibitors were discovered in around 2009 or so. And this trial is still recruiting and ongoing as far as I'm aware.
Yes.
At least the initial data, at least for lupus, seemed interesting and useful. Now, is this a replacement for steroids? I hope so, right? I hope all these new medications that we're coming up with are replacements for steroids. But at least in the foreseeable future, I find it's going to be hard to get rid of steroids completely. Right? Steroids are our go-to. We know they work, right? We don't want to mess around with a medication that's not working or takes time to work. And these trials aren't necessarily designed to help say, like, should I start you off on this or should I start a steroid? Right? Our standard of care is steroids because we know it works. Over time, we might have trials that show that, hey, you're able to get off steroids way faster if you're on one of these medications, and that can be useful. The goal is to minimize the dose of steroids in you, and I think some of these newer medications may aid with that.
Great, thank you. And just full disclosure, Kezar Life Sciences is one of our sponsors. So we are kind of in the loop on that. So yes, the trial, as you said, is recruiting. So if you meet the guidelines, you have to have a CK of, I believe it's over 1,000 or
1,000.
Yeah, I believe something. So if you look at those, this is one of those ways that you could get involved in clinical trials to help move the community forward, right? So I put the link in the chat section. If anyone's interested to look at that, please feel free to do so.
And okay.
Sorry. Go ahead, Lynn. Sorry.
Oh, no, I was just going to say, we did have a question in the Q&A box that kind of asked a question about the clinical trial for immune-mediated necrotizing myopathy that's ongoing right now. I can't think of the name of it. I mean, it's UCB. I think it's looking at the complement system.
Is it the Raw Pharma one?
Yes, yeah. Raw Pharma, UCB, yeah. Can you give a little update as far as you know on that?
Yeah, sure. That's the Xyluka plan study. I was working on that previously, and it's, as far as I'm aware too, that they're still recruiting. I know we had some difficulty recruiting, and then all of these trials have been slowed down by COVID, unfortunately. Mm-hmm. Right? I think there's always hope around these because they attack the immune system in a different mechanism that's getting more and more specific. Right, the way cancer has been doing. I think if we model ourselves off that, I think that's a great direction to go. And so, I don't have the data, and but I'm hopeful that perhaps it would be a nice medication, just like KZR616, that can help patients come off their medications, or if they're refractory, to have some kind of impact.
And my apologies for mixing those two up. When I was talking about KZR616, I know that they are enrolling for IMNM, but poly and dermatomyositis as well. So keep that in mind. The Xyluka plan is for necrotizing. Just to clarify that, I apologize for messing that up.
And I think eventually they may all start to expand over time. And, the goal of these trials is to have a very relatively homogeneous population, right? You don't want to try it on these diseases that are heterogeneous, but we just put them in buckets for convenience and then not see an effect, right? We don't want that to get stuck in the pipeline that way.
Absolutely.
So Jerry, if you could follow up, I'm going to go back and see if I can find the link for the lady who wanted to know more about the
I
the raw plan, the raw chemical clinical trial. Okay, would you go
Sure.
ahead and do that?
Absolutely.
Sure.
So
Thank
the next question, what something's happening with my slides here. um, anti-synthetase syndrome. I know that probably not in all cases, but is it refractory to treatment?
I think you're right about that, right? It's not in all cases, but of course we've come across cases that are difficult to treat, and we typically treat them just the way we treat dermato otherwise, right? We're using prednisone, we're using mycophenolate, azathioprine, sometimes tacro. These different medications are used, but then you end up with patients that sometimes maybe they'll respond a little bit and bounce back, or they continually spiral out of control, and it's hard to really put the brakes on the disease. Um, and those are tough cases. People keep reaching deeper, deeper, and deeper into immunotherapy to say, how can we stop this process? So yes, it could be refractory, and it just takes more and more trial and error, unfortunately. Um, and then also, it's important to keep in mind that we know that dermato, unfortunately, is associated with malignancy in some cases, right? So if something is refractory and you're treating it and treating it and treating it, it's always worth making sure that there's nothing sitting inside you that might be pushing this forward. And we know that anti-synthetase syndrome can sometimes lead to pulmonary hypertension, right? So it's important to get control of this before there's more damage done that cannot be reversed.
Great. Do you know, just a side question about those medications, say, azathioprine, for example, we get kind of some comments and questions where patients, have been on it for, say, a year, had some small improvement, and then it just kind of stops working.
Yeah.
Have you experienced that?
Absolutely. And I think one is to make sure you're on the highest effective dose without causing side effects. So that's one, to make sure that you're doing. Two, kind of going back to the other points, to make sure that you're not on chronic steroids that are making you weak proximally in your arms and your legs. Three, that you're really engaging in physical therapy and getting that strength up the best you can. Right? Sometimes there's a mental block that might say, I'm weak, it hurts, and that's all true. But we want to squeeze out all the strength that we can through exercise and rebuilding that muscle. Now, say we get to a point where we did all this and we're pretty confident that, hey, your CK is up, your aldolase is up, you're still weak, there's other signs of autoimmunity like rashes or joint issues, lung issues, then it's worth reconsidering to say, all right, azathioprine is not cutting it here. We need to try something else. So I think, you work your way up on the dose and then assess the disease. If the disease is still active, you've given it its time, it may be worth considering switching to a different medication.
Assessing for steroid myopathy is the only surefire way, either a biopsy or trial and error as you kind of decrease, taper.
Yeah, and the hope is not to just start doing biopsies to
Right.
find it, right? That will clearly tell you if it's there or not. But a little bit is just the clinical history, right? If everything else is starting to get better, the rest of you, in terms of your immune system, starts to look better, right? Your rashes are better, your strength in other areas is better, but your hip flexors, for whatever reason, are still weak. Is it the disease process? Have you been on steroids for too long? That's something important to keep in mind. And then that's where the trial and error happens, where you say, all right, let's come off this thing here. And all right, steroids are going down. You're not getting weaker. That's a good sign. That means your immune system is under control, but you're still weak, right? So it's not necessarily the immune system that's driving this here. Let's keep going down on the steroids, do physical therapy, and see how much strength we can get out of this.
Excellent. Thank you. I just remember seeing a comment in the support group one time that a doctor wanted to do a biopsy to test for that, and
Yeah.
wasn't sure how appropriate that was.
Yeah, I mean, I think if there's confusion and if you're not sure, some cases can be really tricky. So if you're
Right.
not sure which way the immune system's going, which way the illness is going, sometimes you might have to do a repeat biopsy.
Sure.
But I think a lot of the times, clinically, you should be able to kind of work your way around that.
Great. So the calcinosis is such a painful thing for those who have it. Um, this person submitted a question. Why do I get this, and what can I do for it? Calcinosis more of the issue than the muscle weakness.
Hmm. And that's a good question too. And unfortunately, we are not good at treating this at all, right? And this just speaks to the heterogeneity of our diseases here.
Yes.
That some people get more muscle, some people get more skin, some people get lung, some people get calcinosis, and then we still just call it dermato, right? That's
Right.
kind of funny. And that just speaks to really patients getting engaged in research to help us understand this. Uh, but aside from that, this question, calcinosis, about 20% of folks with myositis end up getting this. And unfortunately, we don't know why this happens. We think that inflammation and damage to the tissue, the blood vessel, and this ongoing chronic process leads to this mineral formation in the skin that absolutely hurts. And it's often later, at least in these adult dermato kind of cases, the juvenile dermato might get them a bit earlier and typically happens in the legs. There's some association with the MJ antibody, but what there's some treatment that we have here. Calcium channel blockers, diltiazem sometimes is used, bisphosphonates, the medication that's used for osteoporosis and surgery. I'm sure you all have experienced that those all don't work all that well, and sometimes these things come back. And that speaks to controlling the immune system, right? So, what's the underlying cause? It's this autoimmunity. And what can we do? And that's where the steroids, and then the non-steroidal immunosuppressants come in to really take control of your disease as best as possible.
Great. And for those that, excuse me, for those that do experience and have calcinosis, there is a clinical trial through the NIH right now through Dr. Lisa Ryder's team. So if that's something that you might be interested in, we've posted about it on Twitter and Facebook, but you can always contact us and we'll be happy to just give you a direct link. And I might be able to get that in time by the end of this webinar that I can post in the chat. So talking about mixed connective.
Okay, Jerry.
Oh, go ahead, Lynn. Go ahead. Sorry, I wasn't sure if you
I'll
were
take
back.
it. I'll take the question here while you go look for the calcinosis information.
Sounds great. Teamwork
Okay,
is best.
great. Thank you. Next question. Polymyositis is part of my mixed connective tissue disease diagnosis, which in this case is MCTD plus scleroderma, lupus, and PM. Are there any special caveats for overlappers like me?
I think the thing to worry about with these overlap kind of inflammatory processes is that while dermato and poly seem to affect muscles heavily, these overlappers can get extra muscle involvement, different organ systems being involved. And I think it's especially important to be vigilant. And I think this is where your team comes into play and where you need to be attuned to your symptoms too. That are my lungs getting involved? Are my joints getting involved? Am I having dry mouth? Am I getting neuropathy? Right? It's not for you to diagnose these things, but I think it's for you to say, I'm having these symptoms and to not dismiss them. So with these overlap patients, yeah, there's some literature that says they have a benign course and they respond to low dose steroids, but they do have lots of non-muscle symptoms that need to be managed and to be highly vigilant about. I see a question about CoQ supplementation with mucositis patients here. I think this idea of supplementation and mucositis, the process is not well understood. The general thinking around this has been throw some antioxidants at it and see if it helps. So as far as I'm aware, the data is not completely clear, but CoQ10 is a low-risk medication. So if it has worked for you in the past, that's good to know, and I would use it. If it hasn't worked for you, I wouldn't necessarily go run and keep trying it every time there's mucositis. The big picture here is that the underlying inflammation needs to be controlled, and symptomatic treatment can be pain control. And then the antioxidants that we kind of throw at it without the best data. But if it works for you, I think that's good, and you should keep up with it.
Mm-hmm. Let's take that next question. There's a question in the Q&A about care team. How important is it to have a care team, especially if you've been managing your myositis, dermatomyositis in this lady's case for many years, and would have to find and assemble a team now?
Well, I think it depends on your symptoms, right? So if your symptoms are well controlled and you're not having complications, I completely agree. You need to pare down that team and enjoy life, right? Stay out of the healthcare system unless you need it, right? I wouldn't want you going back and forth from several clinic appointments where you're just saying, all right, things look good. I'll see you in 6 months. Sometimes you need that, and we need to be vigilant as things are changing, right? So we need to catch this weakness that you might think you're at full strength, and we might capture weakness. But if you've been stable for some time, you have a good routine, you have a good rapport with your doctor, and there's this working communication that you have, I think it's easy to say, let's start paring down this team that I have because I'm doing well. And if I need somebody, I know who to call, or I can go to my doctor who knows someone to call to make this happen on a faster time scale.
And just to follow up on that, to wrap this one up, what about the balance between, your opinion, perhaps a balance between Western medicine and the use of functional neuropathic, naturopathic medicine as part of a care team?
Yeah, I think that's an important question and something that should be worked on together, right? I think your doctor should know what you're taking. And the reason I say that is right, as we're aware, supplements are not managed the same way FDA approved medications are. So, there's always risk that perhaps something was contaminated or it has something in it that might harm you, right? And there's cases of things like this. But I do think where there's low risk, right? Perhaps you're not ingesting something, but acupuncture or meditation or whatever it might be that helps you, I think is important to do. I think there's complementary approaches and there's benefits from both of them, right? And just like Western medicine, there's also harm in the medicines we give. So we just post it that you might get this side effect. So I think having the balance between the two, working with your doctor, and it's not one or the other. It's about you. What makes you feel better and what can work together with the immunomodulatory medications you're on to help you achieve your goals.
Thank you.
Thank you.
Yeah, Jerry, you're up.
All right. So are we looking at the Q&A now, Lynn?
Yeah, I was. I didn't know if there were any more questions. We've got a few more here in the Q&A here.
One about the clinical trial right there that I can field.
Perfect.
So the Avogene trial is looking at gene therapy. It's in the preclinical stage for IBM, and it's looking into muscular dystrophy as well, Duchenne's muscular dystrophy. It's also looking at cancer cachexia. I think all of these things are great and they're important to look into different mechanisms. At least right now, it just seems too early to tell where this is going to go. The field of biotech and these new therapies are just so promising. And, I feel hope from them. I hope patients and families feel hopeful from them too. But I do think that there's a lot of targeted therapies here that are being developed. And I do hope that some of these stick and bring change to the field, which desperately needs it.
Yes.
Yes.
Do you have any experience? Do you know if red light therapy has any benefit?
In terms of your mood? Or
that's the only question that was, does red light therapy help?
I'm not sure in what reference.
Okay,
If whoever posted it could clarify, I'm happy to talk more about it.
great. So Dolly, if you could do that.
The question from Rebecca about what avenues have you found to be successful in terms of managing insurance while taking a multidisciplinary approach?
Oh boy, insurance. Right. It's unfortunate that insurance guides so much of the care. Right?
Yes.
And so I think the goal here is to just be persistent. And a lot of that happens from the doctor's side in office. And unfortunately, not lots of offices are equipped to keep hammering the insurance companies to say, my patient needs this IVIG right now, or my patient needs these XYZ supports, right? And, when I mentioned that your care shouldn't stop just at the clinic, right? I think it's important that you have all the pieces in place where you have your physical therapy, you have your house set up for you in a way that prevents you from falling. You have your house set up for you that eases transfers, eases movements, and minimizes risk for you. Uh, you should have accessibility to your car or whatever else you need. But I think all of these things, if we can't get it through insurance, I think one, we look at our advocacy groups for help, and two, I think we all work together. I think part of the goal of understanding myositis from a more comprehensive point of view is to show that, hey, we are not ALS, we are not cancer, we are myositis. And we have similar problems just like all these other patients. And we do need the funding, we do need the resources. And these are the things that we struggle with. So, the quick answer is there's no short-term fix other than trying with insurance companies, uh, trying with social supports. But in the long run, I hope that as a group, we're able to garner support and increase resources for this community so that you are safer at home. You're able to enjoy what you want to enjoy based off your weakness, your inflammation, and recover the best you can.
Thank you.
Okay, so Jerry, now we got a response from Dolly about the red light therapy and also Blaine. And basically, her clarification is, will it help the muscles feel stronger and better? And then Blaine asked the question, he would want to know how effective red light therapy is on muscles and inflammation and pain.
I see. So those are good questions. I'm not aware of research that has shown positivity for it in humans, but I am completely open to learning and reading more about this. It's not something that I've used or encountered in clinical practice, and that doesn't mean it doesn't work. But as far as I'm aware, that more research on my end needs to be done, and perhaps more research in the field to show that this actually has a clear benefit, right? I think those are two things, but that's something to put on my list to go read about after this.
And we appreciate that. I always appreciate a doctor or anyone actually who can just be honest and say, I don't know, but I will look into it. That so many, not so many, but there has been many doctors that I've been to over the years trying to get diagnosed and so forth, that seemed like they were just kind of winging it. And that doesn't put much confidence in me as a patient. But if they were to tell me, I honestly don't know, but I'll look, that just just makes the whole relationship that much stronger for me.
Yeah, we're all learning, and I think the most important thing is to listen to the patient, right? They're often telling you the answer, right? Is the saying that we hear in medicine. And two is to be curious and not give up, right? Everybody makes mistakes, right? All doctors do, and
Yes.
I've made mistakes. I'm sure other doctors have, and that you've experienced. But to remain curious and work with the patient to say we're not going to give up, right? We're going to keep trying until we find the answer. And whether the answer is we've ruled out all these scary things, and now it's in this bucket of medicine that we say it's idiopathic, we're not sure what it's from, or to say we have a name for it. But I think it's this continuous progress together.
Yes. And for us as patients to keep in mind, doctors are humans too. That can't know everything. So, we sometimes have to, maybe dampen our expectations just a little bit. Is there anything else, Lynn? Any other questions that
Um,
you see?
yeah, we have a comment from Myositis Joe. We'll tell you more about you. If you haven't heard about Myositis Joe Sanchez, he says, do you do road trips?
Okay.
Visit patients in their environment?
I would love to. I haven't been, but part of something that I've always thought about during my training was to go see how patients live, right? And to say, and I don't like keep saying patients because
I know.
they're
What's a
people.
better word for that, right?
You know, you're a person with an illness and we're working with that. So I want to go to people's houses and say, how do you deal with your illness, and help me understand better how we can improve the environment around you to make it more conducive to what your needs are. Right? Coming to this clinic, it's a very one time point kind of event. Right? I measured your vitals. I quickly pushed on your muscles. I looked at your CK. Here's what we're going to do. But going to your house or understanding you at a more personal level gives you a more longitudinal understanding of the ups and downs and what you really need. Right? It might not be more steroids. It might be better accessibility in your house, or it might be closer access to a physical therapist, or room in the house to do certain exercises and do televisits with a physical therapist. So I think I wish it was more part of our medicine culture, but perhaps one day it will be. At least telemedicine, you can show me around with a video.
Let's take a tour.
Yeah.
Yeah, great. Well, we certainly appreciate all of your input, your answers, um, your vision and philosophy of practicing medicine, that the patients and the caregivers are first. For anybody interested in scheduling an appointment with Dr. Bai, the information is on the screen here. He sees patients both at UT Southwestern and the Institute of Exercise and Environmental Medicine. His administrator's name is Debbie Moreno, and her telephone number is 214-345-4654, and she can certainly help schedule an appointment for you. And as we discussed, Dr. Bai has touched on this, and the time for waiting is over. There's many ways that all of us can do something, whether it's participating in a survey or a focus group or a clinical trial or some of these partnerships that we have with outside businesses and other nonprofits. Visit our website, our Take Action page. We'll be updating that with additional opportunities that patients and caregivers can utilize. So we hope that you'll join that. And then I just wanted to quickly touch on our upcoming myositis patient video support session. It's coming up on the 21st. This is the one that's the third Saturday of each month at 3 p.m. Eastern Time. And then if you haven't seen the announcement, we're inviting you to Thanksgiving at MSU. Join us virtually on Thanksgiving evening starting at 7 p.m. Eastern Time. We know the holidays are going to be a little more difficult this year with COVID and not being able to spend time with your traditional family and friends, but we're here for you. You're certainly never alone, and especially on the holidays. And so join us at, like I said, 7 p.m. Eastern Time. We'll start a trivia game at 8 p.m. Eastern Time. So join us for conversation and fun. And then contacting us. Many of you probably already know how, but you can visit us online at understandingmyositis.org. Our general contact email is info@understandingmyositis. Always invite you to please follow along on our social networking sites, and we provide a lot of information that you can share with others to help others better understand what your myositis life is like. Sometimes it's hard for others to understand when we might otherwise look healthy, to understand that we're really going through a difficult time. So thank you. Dr. Bai, did you have anything else that you wanted to touch on before?
I just wanted to thank you all, and really it's a privilege to be speaking to you all. As I mentioned earlier, that I find great inspiration in people like you. Your struggle is not alone, and I think there's people like me, physicians, nurses, physical therapists, a huge network of people that want to help. and want to be part of your care. And I think working together, I think we can bring about change to the field. It's a field that's ripe for change, and I think it will happen. And together we can make it happen. I see some comments there about people watching from all over the place, and that's of course appreciated. And you're completely right. We need to work together without these borders, these artificial borders. There's researchers all over the place, and I'm in touch with people abroad, and I think it's just this goal community that we have to put together and solve this issue.
Right. And I appreciate that. And looking at one final question, and you might not have an answer off the top of your head at the moment, but we have somebody that's living in Bali, and finding a doctor with an experience in myositis really isn't possible.
Mm-hmm.
Do you have any advice in finding a doctor?
So, with all of this COVID and telemedicine, one, I think it's easy to make appointments. So I think a lot of doctors, including me and others, are doing a lot of telemedicine visits. So if there's some data, it's great, right? I'm working with the Aga Khan University in Pakistan to help understand what myositis looks like there. I think, and this is not about money at all. I'm happy, if you could connect me with the patient, I'm happy to chat and understand what the patient's going through and see if there's resources that might be able to be tapped into nearby. So I think that's one way, and there's plenty of doctors who are interested in global health, and that's one of my interests. And one of my goals is to really increase the understanding and education for myositis, definitely in the US, but everywhere, right? Myositis patients should not be limited by their care based off where they live.
And we look forward to working on that with you. And thank you all for attending tonight. I hope that you're as excited as we are at MSU about Dr. Bai and all that he's doing. And we just really look forward to getting started. And this is the first step. So feel free to contact us, and please enjoy the rest of your evening. Thanks again, Dr. Bai.
Thank you
for joining us. Everyone have a wonderful evening.
Bye, everybody. Have a safe holiday.
Thank you.